Hello and welcome to today's webinar with the Accountable Care Learning Collaborative. I'm Mark McClellan. I'll be moderating today's webinar on aligning provider compensation, physician compensation in accountable care. This is a very important topic. It's one that doesn't get as much attention as it deserves. A lot of the focus in moving to accountable care is on the payments going to an organization and the financial models within the organization. And we've got two experts on this topic joining us to discuss it today. Robert Mechanic of Brandeis University and Dr. Sanjay Doddamani of the Geisinger Health System. As you all saw in the webinar invite, we're going to discuss some of the details around these issues of translating the push to accountable care at the organization level and the organizational financing steps into the links to how compensation can best occur within organizations. And getting to the level of individual clinicians is an area where there has not been as much progress, perhaps, not as much knowledge. Rob is going to give some national insights from his work over the years on this important issue, and Sanjay will give us a view from the front lines at Geisinger, including their experience with physician compensation models. So really good and timely topic. Before we get to the substance, just a few housekeeping items before we get started. We are going to review slides, so if you're not already on the Zoom webinar, please click that link on your computer and you'll be able to see the slides as we're going through them. If you're only able to connect by phone, that's fine. I think you'll still get a lot out of this discussion, and the slide deck will be available after the call along with the recording on the ACLC website. We are going to have some opportunities for questions after the presentations by Rob and Sanjay, so you can submit those at any time using the question module that's in the Zoom app on your laptop. So just click on that question button and feel free to submit a question or comment at any time, and we'll try to get to as many as possible. And we'd like to give some additional context when you do have a question or comment by letting the presenters know your name and organization. You can submit as anonymous, but if you can let us know who you are when you submit, it does help provide some useful context for the webinar responses. Now, before we start, just a few quick updates about the Accountable Care Learning Collaborative activities. I want to say how much I enjoyed seeing many of you last month at our ACLC meeting in Washington. Great discussion there of the competencies for moving forward on accountable care effectively. It reflects a lot of work by many people in the ACLC and a lot of our external collaborators. We have more next steps coming on that in the weeks ahead, so stay tuned. Also, I want to let you know about some other activities that are coming up today, but again, just for the agenda today, we're going to go through, after these announcements, we'll get to the discussion with Rob and Sanjay. So coming up, we have a webinar next month, which is going to focus on policy issues rather than here. Here today is really about some very important strategic implementation issues for accountable care. We're going to go back to the policy side because a lot is happening there as well. As you all know, CMMI and CMS have announced some new directions along with their commitment to moving forward on payment reform, and we'll summarize some of those developments over the last couple of months and make some, try to set some expectation about what's likely to happen next, both at the level of payment reform activities and at the level of the broader political environment. Look for an announcement about that, the details for that December 6th webinar with me and Clay Alsbach coming soon. And also, if you haven't already, please mark your calendars. Hope you can make it to our ACLC next member meeting, March 6th, in Las Vegas in conjunction with the 2018 HIMSS annual conference. That's always a good meeting and a good opportunity, not just for an update on accountable care issues, but through the extensive interactions we have with HIMSS, some special opportunities around health analytics and IT issues as well. And again, details for that will be coming soon too. So those are some issues to think about going forward. But right now, I'd like to focus back on our presentation on how to make financial incentives work within accountable care reforms. And we've got two terrific speakers on this topic. Robert McClellan, Rob is a senior fellow at the Heller School of Public Policy and Management at Brandeis, and also executive director of the Health Industry Forum, which is a great collaboration among different sectors of industry on important practical health policy and healthcare reform issues. His own research focuses on healthcare payment systems and the adaptation of organizations to new payment models, so right in line with the topic today. He's a co-investor of the evaluation of the Blue Cross of Massachusetts Alternative Quality Contract, has been a model for how to evaluate and learn from major payment reform and ACO implementation. And he's worked with a wide range of other organizations on evaluations and on advancing the use of new payment models, including organizations preparing for Medicare's Bundled Payment for Care Improvement Initiative. And also very pleased to have with us Dr. Sanjay Doddamani. Sanjay is the Chief Medical Officer of the Geisinger-led Keystone ACO and a Senior Director in Population Health at Geisinger Health System. This is a broad-ranging job with great relevance to today's topics. He works with executive leadership to accelerate improvement of performance metrics across the system and linking internal metrics for physicians and other healthcare providers related to their compensation and other aspects of encouraging better performance to the overall performance of the ACO. And he also works closely with, in this role, with service line medical directors, platform leaders, operational leadership at Geisinger and the Keystone ACO to really make this transition from the goals of population health improvement and ACO success to actual implementation success. So we're going to hear first from Rob and then from Sanjay. After their two presentations, we'll have some time for discussions, but again, submit your questions or comments at any time. And Rob, I'd like to go ahead and turn to you if you're ready.
Okay, terrific. Well, thank you, Mark. So I'm going to talk about today a survey that we've done at Brandeis with a group called the Council of Accountable Physician Practices that looks at the primary purpose was really to look at risk contracting and look at risk contracting across all payers within the system and kind of get a sense of overall what the financial incentives affecting in that we asked a lot of questions about operating characteristics. We asked about physician compensation, we asked about IT, we asked about performance improvement strategies and sort of what they thought were barriers to taking more risk. And so I'm going to talk about that today, which gives a broader perspective. Now I'm looking to see how I can click through. There we go. Okay, we decided to do this. Basically, this was back in 2011. The Affordable Care Act was passed, and you know, people kept asking me, well, which groups are doing a lot of risk contracting? We didn't really know, and so luckily we had another group interested in that, the CAPP. So this was really a convenient sample. I'd say it's an atypical group because it consists mostly of large systems. These are we focused on their employed physician groups, and the reason for that is in the employed groups, they actually knew what their total payment portfolio looked like to go to the IPAs and so forth. The IPAs know what the managed care contracts look like, but they may not know about other payments such as fee-for-service. So we wanted to get just a pulse for a certain group of how much risk contracting is out there. We've done this survey now twice and are in the midst of doing it on a third time. So we looked at how it changed as the ACA has rolled out and the ACO programs have rolled out. We tried to see if we could distinguish differences between groups that are heavy into risk and groups that aren't, and then what are the big hurdles going forward. Okay, so these are the 33 groups that responded in 2013. The groups in gray are actually members of the Council of Accountable Physician Practices, and in red were other groups that volunteered to join the survey as well. So 33 of them. If you look at the list, these are all, you know, pretty big groups, with the smallest being larger than 100 employed physicians, going on up to Kaiser, which is not on the chart because then you couldn't see the rest of the entries on the chart. You can see a lot of variability in terms of the red portion of the bar is specialists, the blue is primary care, and the light green is hospitalists. So we have some groups that are 50-50, and then we have some groups that are more heavily specialist-based. So when we looked across all 33 groups and we asked them to tell us the proportion of their total net patient revenue across 7 different types of payment. And so this is what you get across all of the groups. Now, we didn't weight it because obviously Kaiser would tip the balance. So we basically took the simple average across 33 groups, and 2/3 of the dollars are in fee-for-service. Then you can see global capitation, 16%, along to the other things. We did have, I just mentioned this yellow bar, and the yellow bar are payments that are coming from an affiliated health plan. Now, some of those affiliated health plans capitated the groups, as does Kaiser with the Permanente Medical Group. Other affiliated health plans pay fee-for-service. I believe that's how the Geisinger Health Plan works. But we sort of viewed that because the organization was at risk. We viewed that as being a risk contract. So based on all these slices here, basically we counted fee-for-service or fee-for-service with pay-for-performance as non-alternative payment, and everything else we considered risk, even if it was shared savings, upside only, just because it's a program that goes with a budget. Now, what we try to do is then differentiate across these groups in terms of, and let's see if I have, there we go, okay. We split them into 3 groups. So fee-for-service groups, as you can see, the orange is payment based on fee-for-service, and the chart's dominated by orange. So fee-for-service based was less than 10%, in non-fee-for-service mixed was 10 to 30, and then we jump over to risk-based, where it really starts at about 40% and goes on up to 100%. The blue portion of the bar are payments from affiliated owned health plans, whereas the gray bar are payments from third-party insurers. So you can see we really had, I think, 3 distinctive groups of 10 to 12 groups in each one. Now, when we look at the revenue distribution then, and we called them the fee-for-service groups, mixed groups, and risk-based, you could see our risk-based groups on average were nearly half capitation, whereas our mixed groups had virtually no capitation, but were heavier in the shared savings, and they were also getting payments from the affiliated health plans. So really quite different compositions. So then what we did is we asked a number of questions comparing and contrasting the risk-based to the mixed groups to the fee-for-service-based groups. And so you can see this is just based on the composition. Not surprisingly, the risk-based groups were much more likely to have a health plan in their system. The mixed groups actually almost all had hospitals, whereas, let's see, and we're, okay, I don't have the fee-for-service groups and the risk groups, actually, the larger proportion didn't have hospitals as part of the system. So we asked some questions about implementation of programs. So we asked a section on information tools and a section on performance management tools. It was a 1 to 4 scale on information tools. We asked you what's your level of implementation of these, and performance management, we asked where are you in terms of implementing the program as well, and how advanced is your program. So going to information management, you can see almost all of the groups, regardless of how they're paid, had an enterprise-wide EHR. But when you look at some of the other areas, particularly the data warehouse and analytics, almost all of the risk-based groups said they were fully implemented, whereas very few of the other groups had similar technologies. The same was true to a lesser degree for guideline reminders and disease registries and predictive modeling. Then the same issue around performance improvement initiatives. So on this page, you really see areas where both fee-for-service, mixed, and risk groups were all relatively even in terms of what they were doing it. So doing leadership development, managing pharmaceuticals, addressing readmissions, and so forth. We go to the next slide. Here's some areas where we saw big differences. So now these are groups that said they're far along in implementing these strategies. So the risk groups are trying to reduce admissions, setting up preferred relationships with low-cost specialists and providers. Interestingly here, a high level of them said we're far along in managing post-acute care. We're doing more with high-risk patients. So real distinctions both in the level of investment that risk-based groups were doing, as well as their perception about how far along they were in spreading these programs across their systems. So now we get to the compensation. And so we basically asked the groups to break their compensation model into 5 categories based on, as you can see here, the orange is production or productivity, the light blue is salary, gray is panel size. Performance is basically bonus payments based on objective performance measures. So we had them differentiate that in terms of quality, patient experience, and resource use or efficiency, and then other. And so you can see that, you know, along the risk-based groups for primary care, much more likely to pay based on a panel size or based on a salary. Our mixed groups, we actually have one that's mostly salary, but then as we go through the rest of them, we've got some performance-based payment, but still it's mostly on a productivity basis, and similar with the fee-for-service. So that orange is paying, you know, you eat what you kill, volume generated, and this is the, you know, the majority, even among these more organized, well-developed systems with employed physicians. This is breaking down now the performance-based compensation based on external metrics of performance. And so the orange is efficiency, the blue is quality, and the gray is patient experience. You can see almost all of the risk-based groups had some form of, I'll call it performance-based compensation for external metrics, 3/4 of the mixed groups, and about 60% of the fee-for-service groups. But you can see the numbers are in general higher. I've got 10% denoted here, so only a handful of them are putting variable comp based on performance above 10%. But basically, they're doing a fair amount, but again, we've got a wide variation across the groups. So this is kind of interesting. We decided that we would chart the primary care physician compensation for individual physicians, and this is the percentage of their comp based on production or volume compared with the proportion of their total revenue that is in risk contracts. And so you can see in the upper left-hand corner, that's a relatively, it sort of makes sense, right? We're paid based on volume. We pay our doctors based on volume. Down in the lower right-hand corner, we're paid based on global budget, and our physicians are salaried. And then up in the upper right-hand corner, you have some weirdo groups that are basically, we're paid based on global budget, but we're paying our physicians based on productivity. And you know, not sure how it's working out for them, but my guess is not as well as the other groups relatively. This is just doing the same thing, but looking at the specialist compensation, and you see a very similar pattern as with the primary care, that it's mostly productivity, but some of the risk-based specialists are paid on salary based on productivity. When we look at incentive compensation here, you can see, again, there is somewhat less incentive compensation for the specialists, and the levels of incentive compensation are lower than they were for the primary care physicians. A final piece here, and this is actually slightly more up-to-date information. It's 2015 data where we did some supplemental surveying, and we asked the groups to give us a compensation range. So to say, and they did, we didn't ask for actual salary amounts. We asked for a relative to 100%, where 100% is what you would expect as a general internist, full-time FTE, your expected comp, and how much could you earn either above or below that based on performance. And so here you can see it ranges from about 5% to really 50% or more. I guess actually this 1-4 over, they can lose they can lose 30% or they can gain 60%. So that's actually about 100% variation in comp. So again, groups are all over the map in terms of what they're doing with physician executive compensation. I guess the other thing I'd point out is just, and I can see if I can do this going back, when we talk about quality, efficiency, and patient satisfaction, a lot of times the efficiency was based on either the overall medical group or the practice unit. Quality, it was sort of 50-50. Some was individual and some was based on the practice unit. And satisfaction tended to be heavily tied to individual physician performance. So the last thing I'll say is that, again, as we look at these are very advanced groups, the names they're still by and large paying their physicians mostly based on production, although we find that groups have a higher proportion of risk contracting, they tend to implement alternatives to production in higher amounts. The second thing I'd say, and just it's my observation from talking to a lot of people, is that it is important to have a compensation, a performance-based compensation as part of your toolbox, because it sends a strong signal about the organization's priorities. Think about that group that it's all productivity based, but they're being paid based on global budgets. And I talked to a number of physicians in that group, and they said, well, we're paid to do this. Why would we do anything different? So I think it's a signal, but it's certainly not the only thing, and it doesn't replace, I think, as Sanjay is going to talk about, systems, processes, and culture. It's a supplement. It's not a replacement. So with that, I will turn it back over to Sanjay.
Thanks so much, Rob. I'm always amazed at how much I learn every time I listen to Dr. McCannick speak on this topic, and that original research really takes it to the next level in terms of our own understanding. I'd like to switch gears and talk about some real-world experience. So my background, I'm a cardiologist, and so I do represent the specialty side. I am a Chief Medical Officer of the ACO, where we predominantly support our primary care physicians, although we do have specialists in our ACO as well, and have participated in care redesign and clinical transformation efforts in both primary care and on specialty integration, as well as in transitions for hospital discharges. I think we recognize that we can't ignore the model for physician compensation in the current environment, with so much changing, and with the aim of really improving clinical outcomes. So, my view, as I've put it, is that yes, money matters and the model of that matters, but only to a point, because I think at the end of the day, when you survey physicians at large, and there are many examples of this, most of them look to the higher purpose for why they work, and if asked, what needs to change, only about less than a third of them really focus on salary increases as a primary objective. Many look for help and support and other electronic, technological, and allied clinical support in the office to help them improve the overall care. I don't have any financial disclosures of any kind. I just want to switch gears and talk a little bit more about the organization that I represent. So Geisinger is an integrated healthcare delivery system. Many of you might know it's fairly large, 12 hospitals spread across central and northeastern Pennsylvania, and extending all the way from Harrisburg up to northern Pennsylvania and sort of bordering towards the Pittsburgh side, as well as to the New Jersey border. We are also now in New Jersey with a member of the Geisinger family, the Atlantic Care Health System. What's interesting is that the majority of our physicians, 1,600 odd physicians, almost 1,000 advanced practitioners, all changed the model of how they were being paid as of last year. And so this was reported in Modern Healthcare. Changing how doctors get paid was the article, and it cited the fact that we did away with physician bonuses or incentives altogether and put all 1,600 of our employed physicians on a straight salary. I think that's going to at least be relevant to the next few slides on how then do you exact a change and improve quality and outcomes when you've just removed that whole incentive component. At Geisinger, we are partnered with area hospitals that are non-Geisinger hospitals, as well as large physician practices in an MSSP Track 1 accountable care organization, the Keystone ACO, or lovingly called KACO. We're self-insured, as well as we have our health insurance arm with about 90,000 Medicare Advantage lives, and with the additions of Medicaid as well as the healthcare exchanges have exceeded over 500,000 lives that are beneficiaries within the health insurance side of Geisinger. So this is data from our own primary care looking at the average RVU productivity, which, if you look at the beginning of the decade, has really grown from almost 50% productivity to about 80% productivity where it's plateaued. During the similar period, you see a peak of the direct margin per provider that kind of peaked around $127, and then subsequently over the last 5 years has progressively decreased, where we find ourselves in a pickle of only approximately $70, $70,000, that is, in primary care direct margin per provider. And so this is a bad combination to have. You have maximizing or maximal RVU output, and you have decreasing returns. And so we had to figure a better way of doing care and trying to figure out how we could go all in on an escalating risk model, both on our Medicare Advantage side by increasing the number of patients who are part of our health insurance arm, as well as by the accountable care side with our ACO. And so this traditional model of care had high productivity, but we failed to do a number of things. Despite having great quality on HEDIS and patient experience rising year over year, utilization management was not really the focus, nor was it seen in any of the outcomes. We had ever rising ED visits, as well as hospitalizations, readmissions, and primary issues such as access to care, immediate access for patients with chronic conditions did not seem to be part of that equation. There has also been an increased demand on quality reporting, and so with very little time with physicians sort of on the hamster wheel with that level of productivity hasn't allowed for us to focus on this. So fast forward to the ACO. We, like many other physician groups across the nation have participated and joined ACOs. When you look back to 2012, there were hardly a smattering of 5 to 10% of ACOs, 5 to 10% of physicians participating in this type of a payment model. And now you see that almost 40% of physicians and practices are part of an accountable care organization. So there's been an ever-increasing rise in this model of payment, as opposed to the traditional fee-for-service only model, which has stayed relatively flat, and in fact, over the past year has somewhat decreased. In our own ACO context, Geisinger represents 3/4 of the overall organization, with about 2,207 physicians out of a total of almost 3,000 physicians. And so with the other 900 physicians in the group, representing various community hospitals, large practices, we do have differences in our payment models, because as I cited, about a year ago, we became a straight salaried physician practice within the Geisinger organization. And so our focus has been to sort of lead on quality, improve outcomes specifically related to ED visits and unplanned hospitalizations, and to really get care into the home using a combination of analytics and care coordination, as well as some upstream care. But when you look at the compensation model, it really has been more, despite the fact that most of our primary care physicians on the Geisinger side are salaried, there are salaried and volume incentives at play amongst most of the primary care and specialists who are non-Geisinger and are part of our ACO. So when you splay this out and look at their disease burden or risk capture, as well as the average paid claim per beneficiary per year, we actually don't see significant differences here. If anything, our own care has been slightly more expensive than some of our community providers. We also have a lot more specialty that could be part of that explanation. And there is wide variability with the averages somewhere ranging between 9,300 and 10,900 in this across the KACO organization, which really brings me to question how much leverage there is or exists within the ACO, especially with regards to volume and salary or incentive models, and what those incentives look like. Because so far, incentives have been mainly productivity-based with a small percentage on the quality angle. So in this slide, which looks at the data from 2012-2013, the National Survey of Physician Practices, these were self-reported data, and you see about 1,400 physicians practicing within 632 practices, show data both from being in an ACO and comparing that to practices that are not in ACOs that either don't have substantial primary care risk or do have substantial primary care risk. This data is not very different from what Dr. Mechanic showed. And what I'm bringing to bear here are a couple of points. The first one is that you see some quality-based payment increases on the ACO side. That you do see. But what you also see is that there's really no significant difference between the percentages of either salary or productivity in the ACO versus the non-ACO practices that do not have substantial primary care risk. This is in contrast to the primary care practices that do have substantial primary care at risk. And so my conclusion on this was that ACOs in their current form, at least without an advanced APM, the incentives are not significant enough to really leverage any decreases in productivity-based payments and any increases in salary-based payments. So back in 2012, when we were firmly in the volume sort sort of approach, the RVU approach, or what I'm calling on this slide, the old world, there was an article in Health Affairs about structuring the compensation to include quality, efficiency, and volume. And so what we found is that physicians really do what they are told, and we were, I guess, asking them in some ways and in some components the wrong question, because they did score high on our views, and I showed you that in a previous slide. Due to lack of space, I did not show you that we had year-over-year rises in patient experience, as well as in HEDIS scores and other primary care metrics related to quality. We also had several disease bundles for chronic conditions, such as diabetes bundle and a CAD bundle at play in the primary care environment. And so quality was year over year sort of increasing at an all-time high, but it did not necessarily translate to decreasing total cost of care or utilization. And it actually created a bottleneck with regards to access to a primary care clinic for patients with chronic conditions. This year, we moved to a model that is very different, really focused on panel size, optimizing physician panel sizes to about 1,800 patients and advanced practitioners to just over 1,000 patients, providing physicians longer duration office visits for the Medicare and similar age groups. The focus has been on access to patients with chronic conditions. This has also resulted in a decrease of office visits for certain segments, the worried well, patients with commercial insurance who really don't have multiple comorbidities and who do not need to be seen 4 times a year, in contrast to patients with multiple chronic conditions who need to have an opportunity to be able to come in at short notice, as well as have scheduled time face-to-face with their providers. There are also EMR enhancements, including a whole host of work around the inbox or in-basket. We had instituted processes within the primary care practices that fostered a team-based environment. These included daily and weekly huddles, as well as continuing to build on the monthly medical home meetings that have already been in place for a very long time, ever since we were part of a PGP demonstration back in 2005. So when I look at what the ideal primary care medical home looks like, it really focuses on the optimization of panel size and increasing the flexibility for longer duration visits, as well as reducing the number of face-to-face visits and increasing the care team. This is data from the Healthcare Collaborative, now Kaiser, in Washington State from Robert Reed, that really showed, and if you can click the next slide, I don't have controls anymore. Sorry, just click the slide. The finding of this slide really showed that there was a decrease in physician burnout from 32 to 25% as a result of making these changes. And so I think the last few slides really do focus on that. So within the next 3 minutes, I'll summarize to say that physician burnout has to be an important component of the overall compensation model, if you like. So and as you all know, burnout is the syndrome of depersonalization, emotional exhaustion, and low personal accomplishment, both at work and at home. It was a #1 feature of our own physicians in the survey that we had, which had almost a 92% response rate. And we see this, this is AHRQ, again, there was a great article on physician burnout. And when you look at that, as well as data from Steve Swenson's group that was featured in the New England Journal, physician leaders citing that their own physicians complained that burnout also leads to decreased quality of care and has a bad effect on the attitude of the rest of the healthcare team. And so part of the overall clinical transformation in primary care has really focused on managing and eliminating burnout. Some of the strategies, and I won't read over this entire slide, has been in helping with EMR enhancements, encouraging immediate access and creating longer duration visits to make these visits unrushed for patients with multiple chronic conditions, and fully integrating a clinical care team that partners with the physician to decrease the amount of stress on a sort of a solo provider to a team-based approach. So what has this done to our turnover? Although this is just very early data, you do see that in 2017 as well as 16, we have decreased turnover compared to the year prior. And of course, this is going to be continuing focus, and we are not at the point where we're sort of feel that we've accomplished all those changes. So in summary, I think physician compensation for ACOs are very similar to non-ACOs unless there's significant escalation in the risk. We anticipate to go to an advanced APM and hope to increase that risk model. Decreasing direct margins per provider and high productivity are an unsustainable model that behooves adopting greater financial risk, and that physician burnout is an important factor in provider retention, and providing practice-based support, whether it's through the EMR, financial incentives, decreasing burnout, and improving the care team can really improve outcomes and experience. So the final question I have is, should physicians even be incentivized to do the right thing, or be given the tools and resources to be able to improve flow and ease, assuming that physicians inherently want to do the right thing and don't need to be compensated to do the right thing? So I'll end there. Thanks, Mark.
Great. Thank you both. An excellent discussion. I think Tom Merrill is going to help us with questions and comments that have come in. And I, again, encourage those of you who do have some questions from this thought-provoking discussion to please send them in. And maybe in the meantime, Tom, I'll start off with a couple. And one is, Sanjay, what is the answer, maybe for both of you, what is the answer to the last key question you posed? One of the main motivations was for alternative payment models was to really enable the kind of support for physicians and new care models for other health professionals and associated tools and services that just don't get well compensated under fee for service. And if you believe the models are doing that and that physicians are well motivated to begin with, then it really sounds like maybe it's all about getting the supports right. Rob mentioned that point as well. On the other hand, this term incentivize does keep coming up in the policy discussions and the reform discussions around a new payment models. I appreciate any further thoughts you all have on that.
Rob, do you want to start?
Well, yeah. I mean, again, it's sort of repeating what I said, but personally, I think it's important to have something as a signal. I agree with Sanjay that all the elements of the workplace. If you can make the workplace a great place to work, you can. We talk about at Atrius Health, where I'm involved, job doability. How do we improve job doability? Reduce the administrative burden on physicians. If they love to practice there, if it's a great place to be, I don't think you need a lot of incentive compensation. But my feeling is that again, it signals what's important to the organization. I think physicians aren't always connected to how the organization is paid or what the priorities are. I mean, I think it's important for the leadership to communicate those effectively. But my feeling is that some amount of incentive-based compensation is valuable, even if it's a moderate amount. And I guess a moderate amount, I would say, would be in the 10% range, because it's enough for people to take notice. But you don't have to tie yourself completely in knots over it. The other thing is, picking metrics that people can actually have an impact on. You can structure it in a way that incentivizes teams and practices to do better, so it doesn't necessarily have to, be all weighted on individual performance. And the other thing is that you may want to pick areas for improvement that are not quite what the health plans are asking for. You know, some of those things, again, it's more about coding or checking the boxes. And I think physicians are more motivated if they think what they're working on is meaningful. So, you know, it may be that as an organization, you might want to think about how can we measure things that are really moving the dial on outcomes that we can get behind as quality, not just as box checking. And I think that will increase the engagement levels.
Sanjay, any further thoughts?
All I would add to that is that I agree that incentives are great, especially when they're related to quality and outcomes, but that those incentives that we've been seeing across the board have also included RVUs, and I think that's where the mixed messaging comes in. And so eliminating RVUs from the incentives really helps focus on the immediate access to care and a shift to panel management strategy. And so getting to your appropriate panel size, I think, would then be the focus, as well as delivering high on quality utilization management and outcomes, as opposed to having RVUs enter into any kind of incentive model.
So, but Sanjay, then, now can I just ask Sanjay?
Please go ahead.
Yeah, would your concept though be that you would adjust compensation based on the risk-adjusted panel size, so that physicians would have some choice in their panel size? And if I can develop a really effective practice where I can manage, you know, 2,200 patients because I'm using e-visits and, you know, a lot of other things, would that be tied to compensation, or is just the idea is to get people into an ideal panel size that facilitates this work?
So I don't want to be the authority on this. We're still figuring these things out. All I can say is where this comes into play is where we have a sizable Medicare Advantage population, as well as Medicare patients with multiple chronic conditions. And so the idea of not really increasing the panel size further, but where medical complexity exists, adding other non-physician team members to that, whether it's a medical therapy management pharmacist to help with drug management, titration, and care coordination, and also care at home for some of the patients who are, you know, homebound and who are unable to be seen. So I guess it's a combination of really focusing on optimizing the outcomes for the panels, and, you know, having, as we saw from a couple of different slides, as well as from our own goals of right-sizing the panel to avoid physician burnout.
Gotcha. Okay.
Yeah, great comments. Tom, should I go to you at this point, or?
Yeah, so I do have a couple of comments from our audience. The first one comes from Ken Cohen, who is the CMO at New West Physicians, and more of a comment than a question, but perhaps something you could all respond to. He says, having done full risk Medicare for 24 years, I offer the following observation. Although quality is critical for patient care and does offer some savings, it contributes far less to decrease healthcare costs than does efficiency. I'm struck with the inattention to efficiency in this service. In the survey. We drill down efficiency measures to the individual physician, and it accounts for 30% of the total. So, any thoughts there?
Well, so I guess, you know, one of my thoughts would be, most of these groups that we surveyed, we also had a section where we asked them about reporting and what they're reporting to the physicians. And so, you know, generally we found that they were reporting different kinds of cost metrics, you know, whether it be hospital admit rates, readmission rates. I think it's the risk-adjusted PMPMs are a little harder to interpret from place to place, especially if you're in commercial, where the hospital, one of the problems is that the hospital rates vary, so I guess they have to really try and price standardize that. But so we found among these groups there's quite a bit of reporting of data about cost performance, both as a, you know, generally it was in terms of their practice unit, their practice, rather than as individuals. and certainly at the organizational level they were reporting that. But I think there was, a lot more reluctance to really tie compensation to cost, because there was some feeling, and again, this is based on just a limited number of conversations, but some feeling that they couldn't measure it well at the individual physician, that getting a couple of really expensive patients could hurt people, or being just in a referral network, which I guess you could argue maybe you should change if your referral network's expensive, but being in a referral network with higher prices and higher use. So I think there was more reluctance to tie comp to efficiency, but I certainly get the questioner's point.
Okay, Mark, we have another comment. This one comes from Portia Buchungo, who's coming at us from the Georgia Department of Public Health. And she makes the comment, I think physicians require the right support, especially through team-based approaches, including the types of providers, for example, NPs, pharmacy, support behavioral health, and case management, et cetera, and efficient care coordination processes and resources that can support patient care outside of the health system. So maybe another comment to respond to, or it sounds like she's supporting the assertion about that physician require the right support.
Yeah, and I guess I'd add just to add to that, and maybe a piece of this more in a form of a question. You all both have emphasized the importance of team support for care coordination, medication management, and things like that. In addition to funding and providing those team resources in a reasonable way, any lessons about how compensation for those other allied health professionals who are part of a team should work? Is that straight salary, or should that have the same kind of signal or other performance-based component to align with the team goals?
So I guess, Mark, the only thing I can say, I think, generally for the non-physician providers, they just are paid on straight salary. That may not be true for nurse practitioners who can bill, but for the non-billing professionals, I think in general they're salaried. There's not incentive compensation. I have heard several groups talk about their desire, or at least willingness to consider and desire to think about, although not having actually done, when their performance bonus is paid, to make them to the care team. I don't know of many examples of that, but I have heard several groups discussing it.
So Mark, I'm going to maybe take research manager's prerogative and ask a quick question. We do have a few minutes left. This stuff to me appears really complicated, and groups like Geisinger can experiment. Rob, you mentioned that the CAPP group is atypical. A lot of these organizations were pioneers. What does physician compensation look like for organizations that can't afford a Dr. Sanjay Doddamani? What do they do? We have a lot of those in our members that are much leaner organizations. Maybe some advice for these organizations from where you both sit?
So it's amazing that some of the greatest work has been done from some very lean organizations that are struggling, including public hospitals. So the National Association of Public Hospitals has often puts out data briefs on organizations that are really financially struggling, but have really been transformational. With regards to solo practices, and many of the surveys have excluded solo providers, just as much as Rob cited excluding sort of Kaiser or suppressing Kaiser physicians on one of the reports. It really behooves the fact that many of these concepts are fairly universal. I think the big difference here is not so much on what the inherent size of the organization is or what kind of support they have, as opposed to what kind of payment model they're structured in. And we saw that in the 2017 release of the 2016 data, unembargoed data from the ACOs, that physician-only ACOs that didn't have to struggle with the burden of filling hospital beds and having hospitals part of their ACO did very well. In fact, they did better, and they participated and really had a much higher shared savings ratio compared to ones that belonged to larger organizations that had hospitals. So I'm actually hopeful that this model of care, as long as escalating risk is involved, more risk contracts, physicians with smaller groups can actually do very well in this type of a model.
Yeah, Rob, I'd appreciate your quick thoughts on that too. I mean, this is a little bit of a preview for the ACLC members. We have a new analysis coming out of the just released CMS ACO report, and once again, the physician-led ACOs tend to do better, and many of these are small groups or coalitions of very small groups where you expect the compensation model to be the combination of fee-for-service payment plus the shared savings bonuses that the groups are getting. But that whatever it is, it does seem to be translating into better performance.
Yeah, no, so sort of switch my hat and put on the Blue Cross Blue Shield AQC hat. Some of the best performing groups have been some of the smaller, less resourced groups. And, typically that's been because they've had a very, active, engaged medical leader who can really engage with the physicians. I mean, it's a whole series of things. It's the leader, it's the data, it's the process. But in a number of those groups, they've really, exactly as you said, Mark, what's the distribution of surpluses under these risk contracts? And in a number of the groups, they're predominantly directing it towards their primary care physicians, and some of those groups have really we're talking several $100,000s of dollars for the groups that have performed well and directed it back to the physicians. It was very interesting across the first 10 or so groups that were in the AQC how they dealt with the surpluses, and it ranged from we don't give any of it back, it just goes back into the kitty to support infrastructure, to we give it all back and we don't give any to the hospitals, and we give little taste to the specialists, and it all goes to the primary care. A lot of these groups, though, they're in weaker markets, they're not making as much money. One of their biggest issues was keeping their physicians from getting poached by the big, stronger systems. And so, these risk contracts were a way for them to generate some more revenue that went back to the primary care and keeping them competitive in the salary range. So I think the small, nimble groups, if they have the right leadership, can definitely beat the very large bureaucratic groups. And with these smaller groups, I think the sharing of the comp was generally pretty important, but not again, it wasn't the only factor.
Great. Well, Sanjay, Rob, I want to thank both of you for joining us today. It's been a great discussion on a timely topic, and appreciate both the insights about physician compensation directly and the importance of fitting it into a broader strategic approach on implementing accountable care models. So thank you all. Just a reminder for the ACLC members, keep an eye out for the upcoming emails about our next webinar, about the details for our next ACLC in-person meeting. Thank you all for joining us today, and we look forward to our next steps together.
All right. Thank you, Mark.
Thank you so much.
Thanks, everybody. Talk to you soon.